This conference will now be recorded.
Okay, so is everybody able to hear me? Can you send me a chat message? Because I know most of you have muted your mics. Just send me a quick chat message to let me know that you can hear me. Thank you, Emily. Wonderful.
And I'm just going to say that I can hear you.
Everybody who is joining me today on May 6, 2020 for this webinar where we're going to talk about medical advance directives in the shadows of COVID-19. And I'm now going to share my screen with everybody so that you'll be able to see the PowerPoint. So our first slide for hot topics with advanced directives, you're going to see, lays out for us what our roadmap is today. So we're going to start by talking about how and when should we start having the conversation. And that conversation is not just limited to our clients, but to our family, our friends, our neighbors, people that we gather with, perhaps at church, synagogue, or networking organizations. We're going to touch on what are the benefits of advanced planning. And I hope that that'll give everybody the impetus. If you yourselves don't have advanced directives, I hope that this is going to light the fire to encourage you to do that. Then we're going to talk about who should you be having the conversation with? Because believe it or not, we sometimes think on a narrow basis and we need to think very broadly. We're going to talk about how can we make medical issues and choices understandable for people? Because this can be the toughest part. Once we get them over the hump of the necessity to make the medical advance directive, it's how do we explain what can sometimes be complicated medical choices. We're then going to touch base on different types of medical advance directives, not just a living will, but a declaration of organ donation and declaration of funeral designee. And then we're going to move on to, is COVID-19 a terminal illness? Where does it fit in the host of advance directives? How do we prepare people for it? I'm then going to share with you examples of some advance directive language that I've been using for years that addresses issues like ventilators and intubation, which are issues that are arising in treating people who have COVID-19. And then last and certainly not least, I'm going to share with all of you some of the creative problem solving that elder law attorneys have come up with in the last 7 weeks as to how do we help clients execute these medical advance directives while we're supposed to be practicing safe social distancing. Just bear with me. I'm trying to get this PowerPoint to advance. Okay, so next slide you see is how and when to have the conversation. Now, fortunately or unfortunately, most people are not going to think about or even entertain the idea of making a medical advance directive until something in their life happens, such as they go to the doctor, they have a test, and there's a diagnosis. Or as you see in the dialogue box, there's a serious accident that occurs. Unfortunately, that's usually when people are thinking about these things. If today's webinar sends any kind of message, I hope that message is that there is no magic age and there is no magic time at which we should consider having medical advance directives. The earlier, the better. We're then more prepared. So how do we encourage people to do this? Well, I think that we have to be successfully able to convey what are the benefits compared to what are the detriments of not doing advanced planning. So first, we want to stress to everybody time. And time is something that we many times just don't have a lot of control over. So by doing it early when we're not under pressure, we're not dealing with the diagnosis, we're not facing an upcoming surgery, we're probably more clear-minded to make well thought out decisions that we might want to talk to our doctor about, talk to the specialist about, maybe discuss with our clergy person, friends or family, as opposed to being under the pressure and having very little time where suddenly we've got to make a decision. I think the second benefit to stress for everybody that we come into contact with is it does give some element of control, meaning it allows us to express our choices. Who do we want to be the medical decision maker? What kinds of medical decisions do we want made if we are facing a terminal illness or perhaps COVID-19? The third benefit is to think beyond ourselves and think more broadly about wanting to maintain family harmony and avoid there being disagreements or broken relationships within the family because we didn't communicate when we could have and we didn't put it in writing. And last, I think that it's very important that we explain to consumers that planning can only be done when we are able to comprehend, when we understand what our choices are, and when we're able to make reasoned decisions. So if there is an issue as to capacity or memory or any kind of cognitive impairment, we may very well lose that window of opportunity to engage in advanced planning. And that's when the option we are left with is going to court and having a guardian appointed for the individual that now lacks capacity and didn't make medical advance directives. So you heard me say a couple of minutes ago that I really hope everybody walks away from today's presentation thinking more broadly and not thinking that there's a magic age that we should wake up and do advanced planning. And for that reason, I'm including in my presentation this beautiful photo of Selena Gomez. She started as a child actress on Disney. And at about age 23, she was diagnosed with lupus, which is an autoimmune deficiency disease. So here the message is that as soon as our children or our grandchildren turn age 18 and they are considered a legal adult at that time, meaning they can make their own medical decisions and they can make their own financial decisions. It doesn't matter if mom and dad still have them on the payroll. We want these young adults to have medical advance directives. Well, not every young adult might be diagnosed with lupus or another disease. It is many times heard of that between the ages of 18 and 25, that group has the highest incidence of motor vehicle accidents. So that could happen. And so we don't want parents rushing to the hospital and being told that they don't have the legal right to make medical decisions for their child and they have to go to court and become the guardian. So if those of you who are joining me today don't recognize this gentleman in the Lakers jersey or the photo of him with his wife, this is Lamar Odom, who is a professional basketball player. And the woman in the photo with him is his former wife, Khloe Kardashian. So when Lamar Odom was about 35 years old, this was about 3 to 4 years ago, they were in the midst of a divorce. The papers had been filed. However, the judge had not yet signed the final judgment of dissolution of marriage. And it was reported that Lamar Odom was found unconscious in a brothel in Nevada. Not clear whether he had accidentally overdosed or had purposely taken too many drugs. They rushed him to the emergency room, and because this couple was not officially divorced, the soon-to-be ex-wife was the one that the doctors turned to make medical decisions for Lamar. So again, we need to be thinking about younger individuals. We need to be thinking about making or changing our medical advance directives when there is a major life change, such as a divorce or a marriage. We certainly don't want to forget that baby boomers need to have medical advance directives, people that fall into Generation X, and certainly not caregivers. Many of us being either in the healthcare profession or the legal profession know that caregivers have the tendency to put the caree or the person who needs the care, their needs first, and the caregiver's needs come last on the list. They forget to practice self-care. And many times we do see that the caregiver, due to lack of self-care, runs themselves down physically, mentally, and emotionally. So we want to make sure that the caregiver is also taken care of and that they have made their written medical advance directives. It's not unusual for consumers to ask, well, why do I need medical advance directives? I'm married. Can't my spouse just make those decisions for me? Well, the answer is it depends. It's not a clear black and white answer. You can be married and you can be in a same-sex marriage or an opposite gender marriage. But if you, let's say, are in a second or a third marriage with a blended family, there could be arguing within the family. The best way to avoid that is by having written medical advance directives that specifically designate the people you are giving permission to make these decisions for you. And let's not forget the importance of single unmarried people having medical advance directives. Very important for them as well. So how do we make medical choices understandable? There are some great tools that I'm going to give you the references for at the end of this presentation. I certainly suggest that we always recommend to the clients that they make an appointment to speak with their doctors after meeting with the elder law or the special needs attorney. If you're working with somebody that has a terminal diagnosis, I also suggest that you encourage them to have a meeting and become educated by a palliative doctor or a hospice or a VITAS organization so that they can get a better understanding of what happens to the body's various systems when there's a terminal illness present. And I think that helps people have a better understanding and not rely on fear, rumors, or misinformation that they've heard from neighbors, heard from somebody at the bridge table, or read on the internet. So let's touch base for a minute and talk about what happens in the absence of having a written advance directive. Well, we do have what unfortunately is still a very little unknown statute in Florida called the healthcare proxy statute. So if we have somebody that did not designate a healthcare surrogate in writing, and maybe we don't want to take that next step yet to go to court and have a guardian appointed, we can suggest to the healthcare provider and to the family that the next of kin be designated by the healthcare provider as the healthcare proxy to step in and make decisions for the person that's incapacitated. Now, the statute has a very long list that details the order in which people are designated to serve as the proxy. First on the list is a guardian. If there's no guardian, then they look for a spouse. If there's no spouse, they're going to look to see, are there adult children? And then the list goes further away on the bloodline. We may look to parents if parents are not alive, to siblings, nieces, nephews, cousins, and so on. Now, several years ago, we had this statute updated because the reality was some people don't have very large families, or family members have passed away. They don't have children. So we needed to think about these types of situations, and what the legislature did is they added a new category toward the bottom of this list to include two types of categories. One would be a person such as a friend or a neighbor that knows the individual, or a social worker that is willing to step in and serve as the proxy. So these are some other options under the proxy statute. Now, ideally, we really want people to have written advance directives, but if they don't, then we fall back on the healthcare proxy. Now, the potential downside to using the healthcare proxy statute is that if there are multiple individuals that fall within the category, so let's say the person who is incapacitated has 5 children, 5 adult children. The statute says it is a majority that has to agree. Well, what happens if we can't get people to agree, and people are listening to their own preferences of what they would want, not necessarily what would mom or dad want? That's where we can potentially run into a problem, and a healthcare provider, such as a facility or a hospital, may very well then say, go to court, get a guardianship, come back and bring us the certified order. Until then, we're not taking sides in the family. Now, what if we have an individual who's incapacitated and there is no living will? We don't have an advance directive that gives guidance to the surrogate or to a proxy as to what did this person want? What was their intention? So Florida, again, has a statute that says if a patient is in a persistent vegetative state, meaning they are unable to interact with their environment, they cannot communicate in any intelligent way, then the surrogate or the proxy can consult with a medical ethics committee. And you'll usually find that major hospitals have a medical ethics committee, and on it you will find medical professionals, legal professionals, clergy people, somebody perhaps from a hospice or a Vitas organization, and somebody as a representative of the hospital. And this can also be very helpful to give a more global view and more global guidance to the healthcare decision maker as to what is appropriate to do for this incapacitated individual. And then, of course, we have as our measure of last resort, which is guardianship. So we can go to court and have a guardian appointed if the person is in imminent physical danger, harm, or is not safe. We may be able to successfully petition for an emergency temporary guardian to make medical decisions for an individual. So what are some of the main types of written medical advance directives? Well, first we need the designation of healthcare surrogate. This is designating the person who is being given the authority to speak for somebody that can no longer speak for themselves. It's very important that we encourage our clients and consumers to think of alternate surrogates as well. And there's no limit as to how many alternates can be named in the document. Think of it this way. You want to have that plan B, because what if under plan A, the first named surrogate becomes sick? They become incapacitated. They unexpectedly die before you. We don't want this plan to fall apart. Another way you might try explaining it to the consumer is ask them, have you ever bought a ticket to the theater to watch a play or a musical? Most people will say yes. You can then ask them, what happens if the main actor or actress gets sick? They have laryngitis. Do they cancel the play and refund you your money? And most people are going to say no, they have an understudy. So that's an analogy that you can use here to encourage people to name alternate healthcare surrogates. The next main type of medical advance directive is a living will, which is intended to allow people to express their end-of-life preferences for care should they be diagnosed with a terminal illness, be in a persistent vegetative state, or be in the end-stage condition of an illness, such as Parkinson's, multiple sclerosis, Lou Gehrig's disease, or Alzheimer's. So some of the topics we want to talk about with our clients to help them make informed decisions about their living will is we want to talk about artificial nutrition and hydration. What would you like if it's no longer safe for you to chew, to swallow? And we don't want food aspirating into the lungs. We want to talk to them about pain medication so that they understand, depending on the progression of the disease and the level of pain it creates in the body, as increased dosages of pain medication are administered, they may or may not be able to recognize loved ones. We want to talk to them about whether they want to indicate that the surrogate can authorize hospice services or not. We want to talk to our clients and our patients about what would they want to happen if the two vital functions of the body, which are heartbeat and breathing, were to stop. Do they want to be artificially resuscitated? Do they want to be placed on a breathing machine? How do they feel about those things? Now, I find that one of the most complicated issues to explain to a client has to do with what the medical profession calls a secondary illness. And this is how I do my best to explain it to clients. If you have a terminal illness, your body's immune system is already compromised. It is struggling to fight the terminal illness, and as a result, your body can become more susceptible to things like pneumonia, things that we might be able to treat the secondary condition with by way of antibiotics. But that treatment course is not in any way curing the underlying terminal illness or terminal disease process. So for some people, it may be an issue that treating the secondary illness provides comfort care. For others, it may be that treating the secondary illness is going to give them a little bit more time with loved ones. And for other people, they may choose that they don't want the secondary illness treated at all. They've come to a place of acceptance. So those are some of the main issues to highlight when assisting people in making decisions for their living will. The third main type of medical advance directive is a declaration of organ donation. And this is a fancy way of saying it's an organ donor. Now, many people will say, well, I have that on my driver's license. Isn't that enough? And it depends on the person. What I do with a declaration of organ donation is I speak to the client about whether they have specific organs that they want to donate or not. Do they also want to donate tissue or perhaps skin that can be used and grafted for burn victims? So with the written declaration, it gives the client the opportunity to be very specific. We can also provide clients with the opportunity to indicate in this kind of declaration, do they want their body donated for anatomical research and study? Again, some people, due to age or their own medical condition, may not have organs that are healthy enough to donate for transplantation, but there are other people that can still benefit by way of research and study. So it may be advantageous for somebody to make a declaration of organ donation. The fourth type of medical advance directive I call a declaration of funeral designee. And as the title indicates, it's a way of naming somebody that you give permission to make funeral arrangements if you have not done that yourself during your lifetime. And since many people are uncomfortable addressing the issue of their mortality and even planning for their death, I find that this is very helpful, again, to avoid disharmony, in the family unit by having one specific individual as well as an alternate named. It also gives the client the opportunity to designate in the document, do they want to be buried or do they want to be cremated? If they want to be buried, they can choose where they want to be buried or next to whom. If they want to be cremated, it's important for the client to make the decision as to who should receive the cremains. Again, the more clear and specific the client is, my hope is that we avoid fights and we avoid disharmony. The client can also indicate in the document, do they want a memorial service? Would they like a celebration of life? Or do they prefer none of that? So where does COVID-19 fit in to advanced planning? How do we attempt to explain to people its potential impact and the importance of being prepared? Well, I think very simply, we just have to say there is no formula. You know, when this started in our country about 7 to 8 weeks ago, the news was reporting that only older individuals were affected or individuals with compromised immune systems. And shortly after that, we saw that wasn't true. Younger people were contracting the virus. Even some children were contracting the virus. So I think what we can impart and what we can stress to our clients is just simply be prepared. There is the possibility that a serious illness can lead to incapacity. Even if it doesn't lead to death, you might become incapacitated and you may not be able to speak or write or use your hands to use sign language to indicate what you want. So by being prepared, you'll be better prepared, and so will your family and your healthcare providers. I think we also want to stress that if people want their preferences respected, they have to first make those preferences known. And the best way to do that is to put it in writing. And when we talked earlier about benefits of advanced planning, let's not forget that the people that are named as the surrogates or family members are certainly going to appreciate that the client was thorough, that they really thought through these issues. And I think from everything we're seeing, where some people are having to go on ventilators or respirators because the virus is attacking the respiratory system, we all need to take time to think, even for ourselves, in addition to our clients and our patients, how would I feel? What would I want done if I got the virus? You know, we have to lead by example, and we are the best role models for our clients and our patients. So let's talk about practical drafting. What kind of language would be helpful to put in a medical advance directive should a client test positive for COVID-19? Well, when I first started my elder law practice, I did a lot of reading and research because I quickly realized that, number one, not everybody wants a living will. And number two, not everybody feels the same way about end-of-life care decisions, and ethnicity as well as religion play very important roles in medical decisions that people make. So I started doing a lot of reading and research about how different ethnic groups approach medical decision making. Who's the medical decision maker? Is it a patriarch society? Is it a matriarch society? Is it a society where the doctor doesn't tell the patient? And there are places in the world where that is the approach. So as I read more and I became more informed, one of the things I came across was a medical grid that had been prepared by Harvard Medical School. And this is something that I use for clients who have had a past medical issue arise, and they see the world through a different set of lenses. They don't want a very simple living will. They want something that is going to go into greater detail. So, and I'm going to show you the medical grid in a minute. What this medical grid does is it talks first about different types of medical situations that can arise. For example, what if you were in a coma? What if you were diagnosed with dementia or Alzheimer's? What if you were a burn victim? And there's even a page in the medical grid that is blank because it is intended to allow the consumer to write what the medical situation would be. The next part in the medical grid helps the client to identify what are the client's goals. For example, does the client want their life prolonged at all cost? Does the client want the medical providers to attempt to cure and treat, but to reevaluate at some point down the road, reassess? Another option for a goal might be that a client chooses to limit treatment to that which is considered less invasive. So maybe they don't want to be intubated. They don't want that tube placed down their throat. And for other clients, they might decide to simply limit it to comfort care. The medical grid that I'm about to show you is then going to talk about different types of medical interventions. So for example, the grid includes providing CPR, cardiopulmonary resuscitation. It addresses intubation. It addresses the use of a ventilator or a respirator. And with each medical intervention, it is asking the client, what is your goal? Not just do you want it or you don't want it, because really it's not that black and white, but what is your goal if you choose to have that intervention provided? And with each one, it asks the client, do you want this provided? Do you not want it provided? Are you undecided at this time, so your surrogate should authorize that type of intervention? Or do you want the treatment tried for a period of time, and if there is no improvement, then stop the treatment? So here you can see is one of the pages from the medical grid. It's called Situation A. And in this example, it is saying that the person is in an irreversible coma or a persistent vegetative state, and that both the person's treating physician and a consulting physician have determined that this person has no reasonable probability of regaining awareness or having higher mental function, no matter what's done. So then, after this is explained to the client works on identifying what is the goal. Do they want life prolonged, all treatment provided? Do they want to attempt to be cured, but have the healthcare provider reevaluate the situation? Do they want to limit the treatment to what's considered less invasive, less burdensome? Or do they want comfort care only? And you'll notice that there's a category called other, because again, people might come up with something that maybe is not specifically identified as a goal, or might be a combination of multiple goals. So I like this grid because it really gets people to think through things and to be very clear and specific as to how they view treatment, what is important to them. You'll then see below the goals are the various interventions: CPR, major surgery, mechanical breathing, and that will encompass respirators and ventilators, dialysis for somebody that might be diagnosed with kidney disease or kidney failure, blood transfusion or blood products, artificial nutrition and hydration, diagnostic testing, antibiotics, and pain medication. So as to each intervention, we want to walk the client through the different choices. Is this an intervention they want? Is it an intervention they don't want? Are they undecided at this time? So they're giving the surrogate permission to authorize it? Or do they want the treatment tried for a period of time, and if there's no improvement, then stop the treatment? And again, this is really meant to start a discussion, to help people to think through the process, to clarify, to encourage them to have a discussion with their physician or their specialist if they have a diagnosis. But it should always be tailored to the needs and the goals of the client. So it's not set in stone. For example, that last category, I want treatment, but if there's no improvement, stop. The client can decide what period of time do they want the treatment provided for before there's a reassessment. Here is the situation that I mentioned a few minutes ago where it's blank lines, which allows the client to think about a situation that the grid does not address that's of concern to them. And I'll share a story about a client. I have a client who is our family veterinarian, and she's an excellent doctor, a wonderful human being, and one of her best friend's fathers was burnt over 70% of his body. And after watching what he went through, she called me and said, I want to make a more detailed advance directive, and this is what we used. And so she used this situation E page to compose what her feelings were about if she were burned and over what percentage of her body, because this was something important to her because she had actually watched it happen with somebody that was close to her. For somebody else, it may be a different situation, but I like the grid because again, we're tailoring it to people's needs. You know, many times consumers will say to me, do you think the 5 wishes is enough? And for those of you that are not familiar with the 5 wishes, this was an endeavor between the Florida Bar and the Florida Medical Association to create a written living will that consumers could use. I view it as the start of a conversation. I don't view it as the be all and end all because I think that the medical issues it addresses are very limited. And I think it's our job to help people understand that more complicated issues can arise and they need to think about them while they're capable of doing that. So here's the brain teaser for Wednesday. Can an attorney include in a medical advance directive intervention language that is contrary to Florida law? For example, euthanasia or physician-assisted suicide. Now, what I'm about to say is my own personal professional opinion. I do not think we can nor should we include that language. I think if we did, that would be misleading the client to believe that it's authorized in Florida when it's not. However, it's our job to be creative and to go beyond boundaries and go beyond limits. And so because some clients will actually consider relocating to another state where euthanasia or physician-assisted suicide is legal, is acceptable, we might want to consider using drafting language that would address just this, that if the client were to relocate to a state where it is legal, this is the preference, and then we would spell out what the preference of the client is. Now, I think that it would be important to encourage the client before doing this to also discuss it with the people that they're going to name as their healthcare surrogate and make sure that they are comfortable, because it may fall upon them to be involved in relocating the client to another state. The client may not physically be capable of doing it, or it might fall upon the shoulders of the healthcare surrogate once the relocation has taken place to find a physician that is willing to do this, to assist the client. So I want us to encourage clients and patients to have the conversation with their surrogate. We don't want a surrogate being in an uncomfortable position that they then become immobilized. So let's talk about the challenges that COVID-19 has placed on the legal community in their efforts to help people by writing advance directives. How do we get them signed? What do we do? So let's first go over some of the basics. Florida law requires a designation of healthcare surrogate and a living will to have two witnesses. Now, here's where it gets a little sticky. With the designation of healthcare surrogate, one witness cannot be a spouse or a blood relative, and one witness should not be the surrogate themselves. So this has definitely been a challenge, because in the last few weeks, as I talk to families, many families are gathering together in one home. You've got the grandparents, the parents, and the children. And neighbors are not necessarily willing to take the risk of being a witness. There is nothing in the Florida law that requires a notary in order for the designation of healthcare surrogate or the living will to be valid. Thank goodness for that. Notary is required for other documents like a durable power of attorney, a last will and testament, and a trust. And we do have a unique statute in Florida that allows a notary to sign a document for a client if they're unable to do this. And I've done this many times for clients that have an illness that affects their ability to hold a pen or their hand is shaking. So this is one creative solution if we need to do documents like a power of attorney, a will, or a trust during the quarantine. But one of the very practical solutions that we've come up with is for the client to contact their bank, and if the bank has a drive-through, to ask the branch manager whether they would be willing to allow two bank employees, by using the drive-through window, to watch the client sitting in their car signing the healthcare surrogate and the living will, then passing it through the tube to be signed on the other side by the witnesses, and then returning it to the client. I've been able to use this successfully in the last few weeks with several clients. The second creative solution that we're starting to use is involving clients driving to the office parking lot, staying in their car. They're wearing a mask, they're wearing gloves, and I and my staff are outside the car, also wearing a mask and gloves. We are putting the documents one at a time on a clipboard, handing them to the client to sign, and then we are witnessing and notarizing. Now, also for our safety, because there's some uncertainty right now, and you can go to the CDC website and look at this, is how long does the virus stay viable on paper, as well as other surfaces? So I've questioned, is it the best practice to keep the client's paperwork in the office? Some attorneys have suggested spraying the paper with Lysol, waiting a few days, and then making the copies or scanning. What we're considering doing is I have on my iPhone an app called Tiny Scanner that I've used successfully in the past. And so we may very well scan the documents while we're outside. Then we can give the documents right to the client in their car. And we can then, from our computers working remotely, put the PDF documents together, organize it electronically, and then we have that permanent record of what was signed by the client. So where should clients keep their advance directives? You know, this might be what you think is a common sense issue. Why do we have to discuss it? But believe it or not, too many clients take all their legal documents and they lump them together and they put them in a safe deposit box, or they don't give copies to the surrogates or to the treating physician. So accessibility is more important than we realize. I think it's important that people not only have the paper copy, but they have digital. Some clients like to have it on a thumb drive, or they ask that we email it over to the doctor's office or to the surrogate. There is an app that the American Bar Association is recommending called Milo, Mind Your Loved Ones, where the advance directives can be stored directly on an iPhone or an Android phone. So God forbid, let's say somebody is traveling or they're in their car, they can have the access. It's not going to be the answer to every situation, because there's the what if the client's unconscious. We still want to make sure that copies got to the healthcare providers and got to the surrogates. But this is a great digital backup plan. So I'd like to share with you some resources that I have found helpful to be a more effective practitioner. And I've included a website that you can go to better understand how people who are members of the Jehovah's Witness Church view advance directives, especially because there is a specific position when it comes to the use of blood or blood products. I'm also sharing with you a resource should you work with people that are Jewish, whether they are Orthodox, conservative, or Reform. There are some differences in approaches. So it's important to understand how different religions affect medical decision making, and ethnicities affect different decision making. So my last resource that I've included talks about how cultural attitudes play a role in belief systems as well as values. And I'd like to share with everybody some of the other webinars that I am hosting this month for National Elder Law Month. The next one will be next week on May 13th. And it's the top 10 estate planning mistakes to avoid making in 2020. After that, on the 15th and the 29th, it'll be repeated. We have a webinar called Don't Try This at Home, the Dangers and Pitfalls of Applying for Medicaid and VA Benefits Yourself. On the 20th, we have a webinar called How Elder Law and Special Needs Attorneys Can Help People Diagnosed with Chronic Illnesses, such as MS, Parkinson's, ALS, or dementia, to help them maintain independence and autonomy. Don't miss May 22nd. The webinar is called Life Lessons from Disney Movies, and it's a presentation you will very much enjoy because it'll take you back to your childhood, and we're going to talk about how different Disney stories and characters actually teach us great life lessons that we can use now. And then at the end of the month, May 27th, we have a webinar on top 5 planning tips that every parent of a 17-year-old special needs child needs to know to plan for their future. So at this point, I'd like to ask if anybody has any questions. Please feel free to unmute your microphone, or if there's anything you'd like to contribute based on your personal or professional experience with medical advance directives.
May I?
Hi, Joanne. I can see your face.
Hi.
But I
Now you can see me. Hi, everybody. It's great to see my Broward colleagues. I'm coming to you from Long Island, and I actually went to the meeting on the wrong computer, and I couldn't get mic'd and I couldn't get the video, so I had to get the laptop, and I had a couple of technical difficulties, but I made it. A little late, but I made it. So hi, everybody. You know, in New York, which is where I'm primarily, but still practicing actively in Florida, we have a default healthcare proxy law. I did not know that.
I cannot hear anything.
Oh,
Can you check your volume button for, please?
can you hear me now?
No, I can't
Oh
hear
dear. That's odd, because it was working on.
The rest of us can hear her.
Oh, Stephanie, is it you?
No, that's Emily Moore. I'm in my
you. I
kitchen,
can hear
so
you.
I'm not
And I
focused.
know
Right.
Emily's trying to say something as well.
So Emily, you can hear me?
Yes, I can hear you.
You know, bear with me. Let me stop the recording. Thank you, everybody, for attending. 1 minute.